Hello, it's June 20th of 2024. It's that Thursday, third Thursday of the month, and we have case conference. Here are some cases I've recently showed people and quizzed them, and now I'm going to quiz you. Patient has a pancreatic mass, and the first thing you look at and you say, oh, there's a mass in the head of the pancreas. It's not going to be carcinoma because it's just too vascular. You also don't see a dilated pancreatic duct. You can't see the common duct here because you don't see the liver, but it's very vascular. Now, of course, what gives you a very vascular lesion, which then washes out, that you can see it's solid and has some rim enhancement. You see the kidneys, they look okay. It could be metastatic renal cell carcinoma if the patient had a renal cell, particularly clear cell. That would be a possibility. It could be other mets, melanoma, for example. It could be a neuroendocrine tumor, and in fact, when I see a vascular lesion in the pancreas, the most likely cause is going to be a neuroendocrine tumor. It doesn't have the look of other things, but remember, I've shown in conference and I've discussed and I'm working on the issue with serous cystadenomas, that occasionally serous cystadenomas solid types are very vascular and look identical to neuroendocrine tumors. Here it is nicely on the venous phase, mass well defined, no dilated duct. Portal vein, SMV, all look good, there's no vascular invasion. And although neuroendocrines are the tip of my tongue, this ended up being a serous cystadenoma. And again, it's a really difficult call. There's an article in Abdominal Imaging this month talking about some of the challenges of solid serous cystadenomas, how they look identical to neuroendocrine tumors. So it's just something to think about. Incidental findings: cystic lesion, tail of pancreas. Lesion has thickened wall, peripheral enhancement, which you can see probably better here. Location-wise, cystic lesion, I could think about a mucinous cystic neoplasm or MCN, but the problem there, of course, is usually they're not so vascular around the edge. They may calcify. It's usually a middle-aged female, but doesn't necessarily need to be. Whenever I see a cystic lesion, usually they're smaller, but with peripheral enhancement, I'm always thinking about a neuroendocrine tumor. Serous cystadenomas is mucinous cystic neoplasms, IPMNs, all are some of the various cystic lesions, SPEN tumors, but they don't typically have this homogeneous rim enhancement with often a thickened rim. That's going to be a cystic neuroendocrine tumor. So again, one of the things we like to show people in conference is not to show the typical appearance of things, but perhaps the less than typical appearance. Again, another pancreatic lesion by tail of pancreas. It's about a 1.5 centimeter lesion. The question, of course, is this really the pancreas, right? Or is it something else? This could be a splenule, but it doesn't look like the spleen. It's lower density. Doesn't look like a cystic lesion per se. Doesn't look like a vascular lesion per se. I could think about an IPMN, but they're usually more cystic. It looks well defined. Could it be something pushing like a lymphoepithelial cyst of the pancreas, but usually they're larger and more cystic. I'm kind of stuck with this. What do you do with this case? Here it is again. It's definitely a lesion there. You can't leave it alone, I guess, is the answer. When this was biopsied, believe it or not, the thing that maybe helped me the most was this little tiny area, which is not high density, but is calcification. This was a neuroendocrine tumor. Again, boy, it ain't always easy. When people show you articles or a conference, they always show you the typical cases. It's the atypical ones which will get you. And there's also the atypical ones that make it hardest for us when we train AI. Abdominal pain, cystic lesion pushing on the stomach. It could be a number of different lesions, but let's say it's pancreas. What gives you such dense calcification? Stellate calcification, central calcification, serous cystadenoma. Peripheral calcification, SPEN, MCN. Old hematomas can calcify and look like this. Old pseudocyst can calcify. Maybe it was from hemorrhage or just a pseudocyst in a patient with pancreatitis a long time ago, or a patient who had trauma. You can see it beautifully on the patient's cinematic rendering. This was resected and was a pseudocyst from pancreatitis, oh so many years ago. Another case, neck pain. You look at the left neck, looks good. Right neck, there's a soft tissue mass present, right? Now this is arterial phase imaging. You can say an abscess, local inflammation. You can go through processes, but as you go to the venous phase, you can see that there's a vessel here. That vessel is thrombosed, peripheral rim enhancement. It's the jugular vein. Compare right and left. Beautiful, beautiful example of jugular vein thrombosis, peripheral enhancement. There's a catheter present here. The most common cause of jugular vein thrombosis, you could say local infection, but it's typically a patient who's had a catheter placed even for a day. We once wrote a case report about that, but the longer the catheter's in, the more likely it is to cause problems. And this was a catheter giving local inflammation and eventually jugular vein thrombosis. GI bleed, I don't see a site of bleeding here, but what about the stomach? There are these multiple low density, what look like polypoid lesions. You can see that we're catching them here as well. They're throughout the stomach. They're not high density. You know, when you see filling defects in the stomach, you can think about familial polyposis, juvenile polyposis. You could think about neurogenic tumors in a patient with Zollinger-Ellison syndrome. But these are very low density, they're water density. What do you have? Here it is as a polyp with a stalk. What gives you low density lesions in the stomach, often multiple, as you can see here, that are polyps? And that's benign fundic polyps. These can bleed occasionally. Usually they don't cause any problems. They're an incidental finding, usually like this case in the 1 to 2 centimeter range. Pelvic pain, there's something pushing on the rectum. Could it be an ovarian mass? Could it be some GYN mass? Could it be a mass arising off the colon? It's also really closely related to the small bowel. Could it be off the small bowel? When you get more images with contrast, it's vascular with calcification. And there it is. Look how vascular the lesion is. Changes positions just a little bit. Again, is it something coming off small bowel, large bowel? Is it something in the mesentery? You can go through that whole differential. You can think about a carcinoid tumor. You can think about Castleman's disease. You can think about lymphoma. This was increased uptake on the PET scan. And this was a GIST tumor of the small bowel. GIST tumors are often exophytic, can be vascular, as this case was when we gave IV contrast, can involve and arise from the small bowel or the large bowel. Right upper quadrant pain, large cystic mass in the liver. I put this in to keep you honest. You could say, well, hepatoma. I guess you get a large aggressive tumor in the liver. Hepatoma is a good thought. Cholangiocarcinoma can be low density. This is really necrotic. Could it be an abscess? Well, theoretically, yes, but has the look of one specific mass that is just, abscesses tend to be multiple things like with a cloverleaf appearance. So a big necrotic tumor with rim enhancement, metastatic GIST tumor, metastatic leiomyosarcoma, metastatic GYN tumors are all possibilities. This was a primary fibrosarcoma of the liver. That's very unusual. You could get them arising from the capsule, the liver, or the parenchyma. Just a very unusual diagnosis. Another patient, incidental finding. What am I looking at? Is it the kidney? It looks kind of full up there. Here it is again, it's cystic. There's some rim enhancement. The right kidney looks good, and you get the coronal view. You can tell, oh, it's not the kidney's pushed down. And again, we know you can look at all the images and you could probably figure out if it's above the adrenal, if it's the adrenal or it's the kidney. But of course, coronal 3D maps are particularly good at showing you things. So now I'm talking about a cystic adrenal mass, adenoma, old hematoma, cystic pheos are possibilities, metastasis are possibilities. Here it is on the sagittal view, some increased density, thickened wall, rim enhancement. Again, you also think about a cystic adrenal cortical carcinoma. This was resected after lab values were obtained, and it was a pheochromocytoma. Pheos, 10% are malignant, about 10% are cystic, although we typically think about pheos as solid tumors. They can be cystic, and when they are, it can be more confusing. Right upper quadrant pain, well, the patient had no explanation for the pain, but there are multiple lesions present in the patient's spleen. If the patient was febrile, then one can think about the possibility of multiple abscesses like aspergillosis, candidiasis, but the patient wasn't immunosuppressed and didn't have any malignancy. This was an incidental finding. TB, spleen, liver, kidneys, lung, patients are often febrile. Sarcoidosis is the thing that gives you splenic lesions, can also be splenic and liver, can also have lung involvement, but it's the one that gives you multiple low density lesions. Concern for malignancy is always brought up. Beautiful example of sarcoidosis of the spleen. Typically small lesions under 1 centimeter and numerous lesions. So that's the end. Hope you liked the 10 cases. Hope you got them all right. I got that phone call in the middle, right? That was a spam call. I don't know about you. I meant to turn my phone off, but I seem to be getting a lot of spam calls. And it's not just Trump or Biden trying to reach me, which I think probably all of you get those same calls from every politician. Unfortunately, you could stop the call by law, but you got to be fast enough to stop it, typing in stop or typing in 1. Anyway, on the good note, we had 10 great cases, 10 cases to think about. Also to emphasize the point that we all understand the common appearances of certain pathologies. It's important to also to understand the less than most common appearances, because that's where you can make the most difference to the patient. And with that, I wish everybody a great day.